Pleasure on behalf of Academy of Orthopedic Manual Physical Therapists, AOMPT, Professor Senthil P. Kumar. We had a series of webinars. Okay, almost we have conducted 327 webinars this lockdown. Okay, and I had the privilege to conduct at least more than 310. And we had a good participation from people from every part of the world and also from India. It's a great venture that during this lockdown, we have been keeping people occupied through our free webinars, which the free webinars are predominantly, they are promotional. Okay, you can imagine always anything that is free is always promotional. Okay, but at the same time, we have ensured that it is educational. Okay, that people have to learn. Okay, and the most important fact is, I always believe the development, the knowledge improves only with questioning. Okay, if we stop questioning, if we think that everything is right, okay, or you idolizing the people like Robin McKenzie, okay, he said something, whatever he said is correct. Okay, that's only his students might think. Okay, but those who are actually clinicians, those who are treating patients, will definitely have questions that why some patients I am not able to use the McKenzie concept. Okay, why are some patients not responding faster as much with the McKenzie concept? Okay, with due credit to the founder of the mechanical diagnosis and therapy, Robin McKenzie, who evolved this concept as McKenzie concept, okay, from New Zealand. And it's also the first originated manual therapy concept, a well-structured format, established concept. However, we have over the years, okay, we have people contributing to the growth of the concept, okay, predominantly who are students who started what is called as the McKenzie Institute International, okay, MII, and the website is McKenzieMDT.org. Okay, so where you see here, this group certifies what is called as MDT practitioners, MDT instructors. MDT practitioners, they are certified to evaluate and treat according to the mechanical diagnosis and therapy, which was described by Robin McKenzie. Instructors, they are at a higher level. Okay, so they actually can teach, share the information about the McKenzie concept on an official platform, and also to provide certification from McKenzie Institute International itself. Okay, so this is the scenario. However, with the true credit to the founder, I have never met Robin McKenzie. Okay, so he left us in 2013. Okay, that year. Okay, so what is important here is, I know that people like Robin McKenzie, Jeffrey Maitland, even now alive, Brian Mulligan, a lot of people, they developed the manual therapy concepts in order to benefit the patients. Okay, they were all treating patients, some kind of an observation they got, then they got that flash, that spark, then they developed, they tried using it on the patient, they found that it is really effective. They can't keep the knowledge with themselves, so they shared it with everyone. They wrote the textbooks, especially McKenzie wrote 2 textbooks. Treat your own neck, okay, treat your own back. Okay? This is for patients. The first textbooks what Robin McKenzie wrote was for patients. Then after that, mechanical diagnosis and therapy for the cervical thoracic spine, mechanical diagnosis and therapy for the lumbar spine. Of course, more recently, mechanical diagnosis and therapy for the extremities. Okay. So you can imagine the evolution itself. Originally, it was prescribed for spinal problems. Okay. And later, the extremity from sacroiliac, iliosacral pelvis, and then it came to lower extremity. Then it got now, even research is going on for the upper extremity. Even lower extremity also, there are conflicting research, which is not able to tell that 2 therapists can classify the patients accurately, okay, using the McKenzie's model of classification. About the extremities, I would say all the credit goes to his students, okay, because they are the ones who developed the concept and applied it to upper extremity and lower extremity. But whereas when it comes to spine, it's the original founder, Robin McKenzie himself. In this situation, okay, AOMPT always wants to share knowledge. Okay, we want to provide on different platforms. Either it is a YouTube video links or we provide as a live streaming webinar. Okay, there should not be any barrier to knowledge. Always we believe that learning is life. Okay, that's the most important thing. As long as we are learning, we are alive. Every experience in life teaches us. That's why we tell experience is the best teacher. So here again, I wish all of you the best to experience this session, the best of yourself, so that you get the best out of the session. When Robin McKenzie introduced this concept, okay, how was this experience started? This session, I am going to give some input. Okay, I'm going to give some content. Like till now, I was telling about the history and evolution. Now I'm going to go into the step by step, each of the foundation principles and how the concept is actually. So I'm going to give the full concept. But remember, the topic of this webinar is an extension from the McKenzie concept. Okay, I will tell you why we need an extension, a modification, or an advancement from the McKenzie concept. Okay, although I changed the name of the webinar, Mechano Functional Diagnosis and Therapy, because it's not only just mechanical, we should concentrate on functional. Okay, because patients come to us when they have a functional problem. Okay, that's first and foremost. They don't come to us telling that I have problem with flexion, I have problem with extension. It's not just anatomical. They come to us because they cannot read it. Okay, they come to us because they cannot text. Okay, they come to us because they are not able to look up for 20-30 minutes. Okay, so it's all functional activities. If it is thorax, upper limbs both are reaching forward. Okay, thorax goes into a flexion. Okay, so reaching forward and I am working with my arms, I am getting upper back pain. Okay, it's you who have to tell about pathomechanically that this is flexion of the thorax. The same way, overhead motion, both the upper limbs, when you take up the thorax, which is like this, becomes straightening of the kyphosis. Okay, when you elevate, that becomes extension of the thorax. Overhead elevation, bilateral means extension of the thorax. Reaching forward means flexion of the thorax. Okay, patient comes to us with functional problems, which is upper extremity. Okay, whereas symptom is in the thorax. Okay, so first point, the symptom is functional. Okay, so we need a functionally oriented treatment. Okay, we can't stop with getting flexion and extension. We have to ensure that patient is symptom free in functional activities. So that's the reason why Mechano functional diagnosis and therapy, that need comes. Okay, same way, regional interdependence. That means problem or the dysfunction is in the spine, like I was telling now, flexion of the thorax or extension of the thorax, but symptom is in the upper extremity. It can be even lateral epicondylalgia in a patient who has thoracic flexion or an exaggerated kyphosis. Okay, so what we are trying to see here, impingement syndrome, you are all aware. Okay, if you keep the thorax flexed, okay, I keep the thorax flexed, this is thorax flexed, this is scapular protraction. Okay, this is, you can see that my shoulder is moving, this is scapula, this is thoracic flexion. With thorax flexion also, my upper limb elevation cannot go beyond 80 degrees. Okay, I can only lift my is flexed. If I extend the thorax, okay, if I am upright, I'll see that my arm elevation can go fully. Okay, so spine plays a large role in the extremity mechanics. Regional interdependence is very less discussed in the original concept of McKenzie. Okay, in McKenzie, spinal problem was the one which was described. His students were describing the extremity problems, but they have not come to the fact that even extremity problem can create symptom in the spine. Okay, so you have a problem in the hip, it can alter the pelvis, it can alter the lumbar. especially because lower limb is weight bearing. We stand, we walk, we climb stairs, all are closed kinetic chain. Okay, the weight bearing activities. So it will influence. In upper limb, the position of scapula determines the humerus. The internal rotation of humerus, if it is more, it will create a pronation of the forearm. Okay, excessive pronation of the forearm will create a lateral epicondylalgia. Okay, and also ulnar deviation, if it is excessive, okay, it will create the de Quervain disease. Okay, these are all regional to interregional. Okay, both are there dependence. So what you have to be aware now is the original concept, how much it is effective. The first and foremost, what is called as the scientific evidence. Okay, there are high quality randomized controlled trials. There are systematic reviews which say that McKenzie concept is definitely useful, but for only specific conditions. Which are the conditions? Predominantly discogenic low back pain. Okay, the pain in the lumbar spine, not even cervical. Okay, the research evidence has shown only for the lumbar spine that it is effective. That too, how much effective? Short term to medium term, not the long term. Okay, and they have advised that we can use the McKenzie approach together with the other exercise and active interventions. Okay, so that was a suggestion in the Cochrane systematic review. So now you know, okay, till which extent, which condition it helps. Facet joint syndromes, sometimes you can help them, okay, and you can use the McKenzie concept and try to treat it, okay. However, only in the thoracic region, the facet joint syndrome has been effective, okay. However, those studies are also very less quality studies. That means we tell level 4, okay, like case reports, case series, that is level 4 evidence, not the randomized control trials. Facet joint syndromes, thorax. When it comes to radiculopathy, okay, cervical radiculopathy or lumbar radiculopathy, both are associated with the short-term benefits only. So that means you are treating the cervical spine, there is a nerve root problem which is causing a shooting pain. Okay, you have a sensory problem in a dermatome, you have a motor problem, muscle weakness in a myotomes, okay, all the related muscles, or you find that reflexes are diminished. Okay, all these are radiculopathy. Okay, this radiculopathy also only short term. So here we should know that how can we improvise the concept so that the concept can reach the patients better. If, for example, if you note the indications and contraindications of the McKenzie concept, okay, I am opening the chat now. I want you to put what are all the indications you think that it is for the McKenzie concept. Consider about spine, okay, be it neck or be it back, okay, low back. Just type in what do you think is an indication for the McKenzie concept, right? Starts. You have 30 seconds, okay. One person, you can put one single text message, okay, with any number of points. Okay. Low back pain. Okay. Back pain is a symptom, okay. It's not an indication, okay. Indication means dysfunction, okay, the actual problem. As I was telling you now, discogenic low back pain. That means it tells the etiology. Okay. Facet joint syndrome. Okay. Radiculopathy. Okay. So in the discogenic, yes, Zulfikar has told that disc prolapse in lumbar spine. In the disc, there are varying degrees of injury, right from annular strain. Okay, annulus fibrosus going for a strain. The next one is the nucleus pulposus, going out of the inner fibers of annulus. Okay, these are all multiple layers of annulus. This is inner, this is outer. Inner fibers torn, nucleus pulposus goes, okay, and the bulging is there. That is called a disc bulge. So first is annular strain, next is the disc bulge. Then what you have is every annular layer except the outermost layer, okay, and the posterior longitudinal ligament, that both are intact, okay. and then the nucleus pulposus is pushing that. Okay, so that is called as the protrusion. Okay, so annular strain, disc bulge, disc protrusion. The next one is posterior longitudinal ligament also torn. Nucleus pulposus comes outside the annulus fibrosus. Okay, that is called as the extrusion. Okay, and the last is fragmentation. Nucleus pulposus comes outside, breaks into fragments, and the fragments travel in the cerebrospinal fluid. Okay, in the space, epidural space. So that is the sequestration. Okay, so there are varying degrees of disc injury. And yes, we have some points received from participants. Radiating pain increasing or decreasing with movements. I appreciate that word movements because in the description itself, he mentioned mechanical neck pain, mechanical low back pain. Mechanical means static dynamics. Mechanics include statics, dynamics. Statics means posture. Dynamics means movements. Okay. So either the position is altering the symptoms or movements are altering the symptoms. Okay. Altering means either they aggravate the symptoms or they relieve the symptoms, okay, which is supposed to be mechanical. Symptom, how it will be present if it is a mechanical pain? Intermittent. Okay, that means sometimes you don't have pain. Only when you are exposing to the mechanical stimuli, then the pain comes. When you are removing the stimulus, the pain goes down. Okay, so it keeps fluctuating throughout the day. Intermittent. Okay, that is mechanical pain. Another feature of mechanical pain is it responds to manual therapy because manual therapy is dependent upon movement signs. Okay, we are either moving the tissues on each other, or we are moving the joints, or we are moving the nerves. Okay, so if this is a myofascial treatment, or whether this is articular treatment, okay, or this is the neural treatment, okay, manual therapy always involves movements, okay, or even perceived movements. Okay, I imagine the movements, graded imagery, okay, mental imagery. It's part of pain sciences. Okay, so mechanical, this is the indication. Okay, in simple words, now I ask the participants, what are the contraindications? Can you tell what are the red flags of McKenzie concept? In which situations you can't use the McKenzie concept? Okay, what are the red flags which will indicate a reference to the physician? Okay, or you delay the treatment, you don't give the treatment to the patient. Okay, so I want that contraindications. So can you type that? Peripheralization spelling. Okay. Any other? Pain is not a contraindication. Okay. The type of pain is the contraindication. The cause of the pain is the contraindication. Okay. You don't tell indication or contraindication with the symptom. You tell the indication or contraindication with the cause of the symptom. Okay. What is the problem there? Spinal cord injury. Yeah, agreed. Okay. Yes, it's right. I go to the chat. Stenosis is an indication. Peripheralization is an indication. Pain is an indication. Yes, Keshav is right. Mechanical instability, tumors, infection are contraindications. For the cervical spine, carotid artery blockage is an contraindication. Cramps is, you cannot tell exactly, but you can take it as contraindication. It's fine. Okay, but according to Murali. Spinal cord injury, yes, contraindication. Carcinoma is the tumor, again, contraindication. Fractures, yes, absolutely right. Neha Sharma mentioned that fracture. Pain increasing in extension or it is increasing with flexion. Don't think that it is contraindication. Okay. Basically, what are the contraindications? Think about fracture, dislocation, okay, trauma. In the atraumatic, osteoporosis, metabolic, okay. And then you come to malignant, okay, tumors, carcinoma, infections, okay, TB spine. Again, that is a contraindication. And then you come to autoimmune disorders like rheumatoid arthritis, ankylosing spondylitis. Then you come to the other contraindications of collagen vascular disease, connective tissue disorders, like fibromyalgia, like for example, scleroderma, okay, systemic lupus erythematosus, okay, all these conditions. So these are all systemic conditions. Vascular, peripheral vascular disease, okay, it's a contraindication. Okay. When you talk about musculoskeletal disorders and being a contraindication, rightly pointed out by Keshav was instability. Okay, this is one of the important factor where we find in our patients, they take an abnormal posture, eventually they will have instability. Why? You always sit in flexion. You think that the spine won't be unstable in flexion? It will be. Okay. You can't just give an extension regime without ruling out the instability in flexion. That's the reason. And another, in McKenzie approach, we use a gross movement. That means if I want extension to the lumbar spine, I might do full lumbar spine extension. I am not localizing it to L1, 2, 3, 4, 5. Okay, which segment? I cannot stop the movement at one segment. Okay, because of that issue, if there is a segmental instability, okay, L2, 3 instability, L4, 5 is stiff. Okay, in Maitland you can do the direct one mobilization L4, 5. In Mulligan also you can do to L4, 5, but you can't do that to McKenzie concept because you are having a physiological motion. There is no accessory movements. If it is accessory movements, there is a sustained pressure which you apply on the spine and the patient does the movement. Okay. Either way, when the movement is done, the unstable segment will be the one which will be moving first. Okay. So if there is instability, that segment only is going to move. So you cannot block that. Okay. So you have come to the one of the points which needs the improvisation of the McKenzie concept, because in patients with instability, you need to be careful that you have to modify the technique. Okay, so that's where the necessity for mechano-functional diagnosis and therapy comes. Basically, the ingredient of muscle contraction. Okay, it is in original McKenzie concept. It's always the self-assisted. Okay, the patient does using their body weight. Okay, they take the support on the hands, or they take on this for the neck, for example, or they take the support of the wall, okay, for the extremity. Okay, you just keep the upper limb, you keep the upper limb like this and then move the body. Okay, so all this will become a McKenzie concept, but we should involve muscle forces, active forces. Nowadays, the role of muscles have been explored more. Recent research has come to the fact that every musculoskeletal disorder patient, they require what is called as neuromuscular training, proprioceptive training, and stability training. Okay, so we need motor control there. So MFDT, the mechano-functional diagnosis and therapy, incorporates muscle contraction. Okay, and which muscles? The stabilizers. Which are the stabilizers? The oxidative muscles, the red fibers. Okay, the muscles which are for stability. For example, in the spine, multifidus. In the upper cervical, we have the flexors here. Okay, we have these what is called as longus colli cervicis and capitis, and we have the rectus capitis anterior. Okay, all these muscles are short muscles. They are stabilizers of the upper cervical spine. Even for the mandible, we have a stabilizer, that is suprahyoid muscles, the muscles of the tongue. The tongue muscles stabilize the mandible. Okay, jaw muscles only move the mandible. They are mobilizers. Okay, tongue muscles are stabilizers. The same way, rotator cuff in the shoulder, the lower trapezius in the scapula, they are all stabilizers. And then you come to abdomen, lumbar spine. Of course, transverse abdominis. Nobody can ignore the role of the transverse abdominis as a stabilizer. Also, posterior fibers of the internal oblique, together with, of course, the multifidus. Okay, these are the stabilizers. Then we come to pelvis. In pelvis, mainly the stabilizer is the pelvic floor. And pelvic floor together with the diaphragm, both are part of the core. Okay, laterally transverse abdominis, posteriorly multifidus, superiorly diaphragm, inferiorly pelvic floor. Remember the concept description by Peter O'Sullivan from Australia, where motor control retraining. Okay, it's an important aspect. For the neck, think about Gwendolyn Jull for her role in investigating the upper cervical, deep cervical flexors, endurance training in neck pain, cervicogenic headache, okay, all of these conditions. So stabilizers activation is very important. You activate the stabilizers and then do the movements. You don't expect the instability to get provoked because you have supported it with muscles. Okay, so the McKenzie concept can be applied to the instability also when it is not mechanical diagnosis and therapy, but when it is mechano-functional diagnosis and therapy. Okay, so here we got the first point, right? I know the participants will bring it. Okay, when we discuss about the MDT, definitely the drawbacks will come out, and we are going to have the foundation for the MFDT. Okay, the mechano-functional diagnosis. Next, categorization of patients. Every patient is grouped into either of these three categories. Okay. Once you identify that they are mechanical, and once you know that the contraindications are not there, you're going to subgroup them into three categories. One is the postural syndrome, where they have abnormal postural alignment. Okay. Second, dysfunction syndrome, that is abnormal anatomical alignment. Okay. Third, derangement syndrome, abnormal structural, what is called as, there's an injury to the structures. Okay, derangement. Okay, so there's a damage to the tissues. In postural syndrome, there is no damage to the tissues. Okay, it's only the abnormal posture that is a problem. So patient might have an abnormal posture. You are instructing the patient to correct the posture. Patient tells that my pain is better, it's reduced. Okay, that means the pain was caused by the abnormal posture. You corrected the posture, pain disappeared. Okay, so that is postural syndrome. It comes for spine and also for extremity. It's the first stage of any kind of a mechanical pathology. Okay, all of us will have some abnormal posture. We'll have some pain. We correct it, the pain goes, but still again we go to abnormal posture. Okay, again we get the pain, then we correct, then the pain goes. Okay, if we go to a point where the pain do not go, okay, then what we do is we try to do something to relieve the pain. And when the pain affects the activity, again you are not able to watch the TV, for example. Okay, it affects the activity, we come for therapy. Okay, so this is the typical progression of a patient. Okay, so with due focus, give your emphasis on the classification: postural, dysfunction, and the derangement syndromes. Dysfunction syndrome is joint alignment instead of the normal alignment. Okay, it is slightly out of alignment. I'm not telling it in terms of subluxation or dislocations, where it goes totally out of congruence. It comes back, it is subluxation. Totally out of congruence, and it is not coming back, that is dislocation. Okay, I'm not talking about that. I'm talking about a minor, what is called as a minimal out of position of the joint, which creates an abnormal movement in this direction. Okay, excessive movement in this direction, or restricted movement in this direction. Okay, so for example, if it is normal alignment, this will be there, this also will be there, both will be equal. Okay, I'm telling about a hypothetical synovial joint. But if the joint position is like this, okay, the joint cannot bend this side because it will be blocked. Okay, and whereas the other side, it will go more. Okay, so the total range, initially it was 20 degrees this side, 20 degrees that side, total 40. Now it will become 30 degrees one side and 10 degrees other side. Okay, so that is because of the dysfunction. Okay, so in this dysfunction, the problem is the alignment, anatomical alignment, and you can correct the dysfunction by movements. Okay, because if the joint is in dysfunction, okay, like this, you just keep moving, you might find that the joint has come back into its place. Okay, repeated movements might correct the dysfunctions. Okay, so this is the difference: the postural syndrome versus the dysfunctional syndrome. In postural syndrome, joints are only they are elongated, okay, or they are what is called as the muscles or the pain sensitive structures are stimulated. That's all. Okay, there is no alignment problem. In dysfunction, there is an alignment problem. Okay, facet joint syndrome fits into the picture of dysfunction. In disc pathologies, disc protrusion comes with dysfunction. Disc bulge and annular strain both are postural syndrome. Okay, and then you come to the derangement syndrome, where there is a tissue damage, where there is a local inflammation because of the irritation of the inflammatory substances on the free nerve endings. That is called as derangement. In the disc, it is the extrusion and sequestration. Okay, both are considered as derangement syndromes. So, does not mean that lumbar intervertebral disc prolapse, so it is a derangement syndrome. No. Okay. It does not mean that there is radiculopathy, so it is a derangement syndrome. No. Okay. It is the extent of the damage. If bulge is causing the radiculopathy, it is still a postural syndrome. If protrusion is causing the radiculopathy, you will tell it is a dysfunction syndrome. Whereas extrusion with the radiculopathy, constant symptoms will be there because nucleus pulposus has chemicals, proteoglycans, glycosaminoglycans, various substances. So the matrix metalloproteinases, okay, all this. So they will attack the nerve root and they will create symptoms throughout the day, 24 hours, non-mechanical. That comes because of chemical irritation. So that is a derangement syndrome. Okay, during that stage, remember dysfunction syndrome, there will be a restriction in one direction, there will be excessive movement in the other direction. But the correction of the posture will not relieve the symptom. Okay. In postural syndrome, you correct the posture, relieves the symptom. Right? In dysfunction syndrome, you correct the posture, it will not go. You have to correct the position. Okay. Segmental alignment. Then only the symptom goes. Okay. In derangement syndrome, we go to what is called as centralization or peripheralization. Okay. That means symptom migrates proximally towards the spine, or symptoms migrate distally towards the periphery. That is peripheralization. You cannot tell peripheralization is a contraindication because if I know flexion is peripheralizing, I will try to do the extension, okay, so that I can treat with the extension because I know that flexion is causing peripheralization. Okay, it contraindicates only the flexion, but it does not contraindicate MFDT. Okay, the original approach itself. So these are the three categories: postural syndrome, dysfunction syndrome, derangement syndrome. Okay, I am giving you an example. Can you just mention what syndrome it is? Okay, the classification clear. You're going to put it on the chat after I complete the description. Okay, I am squatting for a long time. Squatting, full squat. Okay, on the floor. I am squatting and then I am washing the floor. I'm cleaning the floor. I start getting hip pain when I get up. Okay, when I stand up, after 1 minute, I don't have hip pain. So what is the syndrome? Over to the chat. Absolutely right. Zulfikar, he mentioned about it is postural syndrome. Okay. It's really because you are in a position, you are in a posture, you are correcting the posture, it is going off. Okay. The next one. I have pain on standing, knee pain on prolonged standing. Typically, you will think tibiofemoral osteoarthritis. Okay, when I'm standing for a longer time, I'm getting pain. When I am sitting, the pain is not going. Okay, I move the leg. Okay, it was in full extension in standing. Okay, when I am sitting, I'm not able to bend the knee. The range of motion is limited. Okay. What can be the syndrome? Over to the chat. Yes, absolutely right. Ashwina, it is the dysfunction syndrome. Okay. The third, a football player who's playing the game, he kicks the football. Obviously, he has to kick the football. But the opponent kicked the player. Okay. Player's foot. Okay. So what has happened is the foot was stuck in an awkward position of plantar flexion and inversion. You know, foot, plantar flexion, inversion. Okay. Lateral, anterior talofibular ligaments. Okay. Injury. I repeat the word injury anyway. Okay, it's a clue. After which, he's having pain, severe pain, full ankle and the leg, what is called as referred pain. Okay, it spreads because of the inflammatory substances irritating the free nerve endings. Okay, you are doing dorsiflexion, patient is telling pain is there. Okay, but pain is only there in the ankle, lateral part of the head of the talus during dorsiflexion. You are doing plantar flexion, he gets pain everywhere in the foot and the leg. That means one direction plantar flexion is worsening the symptoms, okay, distribution of symptoms, whereas another direction dorsiflexion is symptom is there, but the distribution is less. Okay, it's only localized in dorsiflexion, whereas in plantar flexion it is more diffuse. Come to the picture. What is this syndrome? Obviously is on chat. Yes, Ritu ma'am, it is the derangement syndrome because we have this peripheralization. Okay, and injury in the structure is there, so it is derangement. Even if there is no injury, but the symptom is spreading. Okay, it's becoming larger distribution and it's reduces. That means it's deranged. Okay, so here we are. Are we actually clinically doing justice in this classification? Okay, you think that all patients fall into either of the three categories? I'll tell you one basic example. Patients have pain throughout the upper limb. You have heard of a condition called as complex regional pain syndrome, which is an extension of reflex sympathetic dystrophy, autonomic disturbances. Okay. Do you think McKenzie concept can be used in such a musculoskeletal disorder? On chat. Complex regional pain syndromes, where there is autonomic dysfunction. On the chat. Yes? No. Don't know. Okay. Three options. We have responses. Yes, it is not possible. Okay. So that means complex regional pain syndromes or autonomic dysfunctions, you cannot use the McKenzie concept. Okay. So that means there are typical type of patients for which the MDT not suitable. In spite of being mechanical musculoskeletal disorder, you cannot use that. Another, I was telling you about three aspects of manual therapy. Do you remember? One, which is this. Okay. What was that called as? Because we have impairment-based reasoning. We try to find three different impairments in manual therapy. One impairment we assess like this. Another impairment we assess like this or like this. Okay, yes, absolutely right. Dr. Paramita mentioned about the term myofascial. Okay, that is the first impairment. The next impairment, what we check like this is what is this? ROM, but for what impairment? It is categorized as articular joint. Okay. What is that which I showed here on my upper limb? I was showing like this. What is this? What is this impairment? After myofascial and articular. Yes, of course, it is neural. Okay. You think neural mobilization or neural mobility in nerves, postural dysfunction, derangement syndrome. Can it be possible? If there is a nerve injury, can it be derangement syndrome? If there is an entrapment neuropathy, can it be a dysfunction syndrome? If there is no compression, there is no injury, but the nerve is tight. Okay. Why nerve is tight? Nerve is shortened, tight, because we keep the joint in the shortened position always in our daily activities. Like we have knee flexed positions always. It's not just only hamstrings go for tightness. We also get sciatic nerve getting poorly flexible. Okay, it will not elongate. Do you think postural dysfunction and derangement syndromes can be applied to nerves? Or yes or no in the chat? Please don't raise your hands because I'm not going to encourage people raising hands. Okay. Can we use this? Okay. Postural dysfunction and derangement syndrome for the nerves. Does it sound sensible? Okay. Enough to use it. Okay. The next part. Did McKenzie described neural dysfunctions? Okay. He said manual therapy. He said mechanical diagnosis and therapy. Did he say about incorporating neural? Yes or no? Yes, it's no. Okay. McKenzie did not describe anything about the neural treatment. Even if there is a radiculopathy, you all are aware that there is also a spinal dysfunction, there is a disc bulge, there is a foramen compression, everything is right. But moving the spine alone is not going to treat the patient. You can treat the spine, but you cannot treat the patient because the nerve root sciatic symptoms which is there requires neural treatment, which was missed in the original approach. So in MFDT, we are going to have integration of neuro-manual therapy. So that means we are going to extend the MDT into applying for radiculopathy, applying for entrapment neuropathies, okay, and also applying for the adhesions or scarring or tightness of the nerves again. So that is going to be the Mechano functional diagnosis therapy, the third ingredient, the unique ingredient. Other than the active forces, okay, other than the autonomic disturbances or even central pain mechanism. Because nowadays the role is not just in the periphery, okay, it is actually central. Brain always plays a part in every symptom, okay. So central mechanisms are very common, and remember that McKenzie does not discuss that because those days it was not very evident for people. Nowadays, you have pain neuroscience education, okay, graded motor imagery. It is very, very extended approach to treat the brain apart from just treating the tissues. So what is happening here is we need to treat the patient. If the mechanism is central mechanism, you cannot think it's a derangement. Patient will have diffuse symptoms, okay. There will be mechanical behavior of symptoms, but that mechanical behavior is represented in the contralateral cortex, okay. That when I lift my arm, it is going to get worse, okay. That is mapped in the cortex, cortical representation of pain, okay. So we need to attach and upgrade the available evidence in order to benefit what is called as patients, because we are treating the patients, we are not treating the tissues, right? So that's where I tell technique-centered approach versus patient-centered approach. Technique-centered approach is indication, contraindication. Patient is not suitable, don't treat. Okay, that is technique-centered approach. We are selecting the patient for the technique. Okay, patient-centered approach is whatever the indication, whatever the contraindication, only the first level you are just going to rule out. After that, even if it is multi-structural problem, you are open enough, Even if there is multiple mechanisms, central and peripheral, still you are open enough. You are flexible enough to include other aspects of manual therapy so that within the McKenzie framework, you can integrate other treatments so that we are treating the patient. So that is where what we are doing is we are selecting the techniques for the patient, okay, to help a patient who's having severe pain or patient who's having a mild pain like an athlete, okay, who's getting provoked after a longer time. Everybody can be treated by varying degrees of combination, okay. In patients who do not have that much pain, in athletes, you can provoke the symptoms to maximum. You can do end range positions, end range movements, repeated testing, sustained positions for longer time, all this according to mechanism. But if a patient is having highly irritable symptoms or the symptoms are fluctuating, too much distribution, everything, you can go in the relief direction, that is the centralization, okay, what is called as directional preference. So you can incorporate within the McKenzie framework, okay. Here we are. So the mechanism, whether it is autonomic or central mechanism, is not addressed. Articular, myofascial, and neural, the neural component was not addressed, okay. Active is important part of functional recovery, where the instability, it's also not addressed. And then stabilizers activation, whether it can help, okay. So these are all the aspects which we can improvise. Next, you are all aware of the McKenzie concept for cervical or for lumbar. Do you know the two types of regime? Either in one direction you give the exercises or you give the other direction of exercises. The McKenzie whole concept concentrates on either you use this direction of exercises or this direction of exercises. What are the two directions? Can you put it on chat? In a spinal pain, do we use lateral flexions in McKenzie? Do you use rotations? No. So predominantly they are either flexion or extension regimes. Remember, the misunderstanding behind the original McKenzie concept is they think that McKenzie concept means extension, okay. But remember, it is only directional preference. You can give flexion also, you can give extension also. Whichever is centralizing the symptoms, you can give that. However, the primary focus was only flexion and extension. Now you tell me, you think that, do you think, you participants think that only flexion or extension, if you are treating, can the patient become normal? Yes or no? Absolutely right. Neha, Keshav, Riya Singh. Okay, no, no, no. Because these are not the only movement that is available. We need lateral flexion. We need rotations. Some patients have symptom only with lateral flexion. Then what will you do with McKenzie concept? Okay, you are not getting a picture with flexion. You are not getting a picture with the extension. Okay, so you are going to exclude the patient? No. Okay, that is technique centered. You are certified practitioner. You are not a certified human being, a clinician to take care of another human being. You have to see the actual three-dimensional picture, not just the sagittal plane. Of course, there was a description by the original concept that scoliosis, okay, was included in the description. What is called as the scoliosis, which a patient is bending towards the symptom side, is called as listing, okay, L-I-S-T-I-N-G, listing. Whereas the patient bends away from the symptom side is called as the scoliosis. That is the convex side scoliosis. Symptom side is here. I bend towards this side, it's called as scoliosis. I bend towards the same side, it is called as the listing. Okay. And there was also another pathology, which is the Michael Jackson pathology. Okay. I tell in terms of what is called as lateral shift. Okay. Shoulder levels are equal. There is no lateral flexion here. Okay. This is lateral flexion. But if I do this and do this, okay, like, okay, that is the Michael Jackson. where you see in terms of lateral shift, okay, was described. Lateral shift is a translational alignment problem, postural problem in the frontal plane. Lateral flexion is an angular alignment issue in the frontal plane. Okay. However, the correction was only translational lateral shift correction was told, but there was no rotational movements. Okay. The actual lateral flexion where you can do that. Okay. So as part of the original description by the concept and over the years also, lateral flexion is not being used for centralization and peripheralization. Okay. Rotation is not used for centralization and peripheralization. I ask why. Okay. Why only flexion and extension? We should assess the centralization and peripheralization in lateral flexion also, rotations also. Okay. So that means it's not just a uniplanar treatment. Okay. We are trying to see all the planes of movement. Okay. So that is where mechano-functional diagnosis therapy comes as again. Okay. If anybody feels that you are seeing a McKinsey concept textbooks, okay, you see the literature, it is totally available openly. YouTube, there are a lot of videos by the McKinsey Institute from various countries. I have put that openly. If anybody thinks that you know better, okay, I'll give you a free 1 hour. You can always explain. Okay. So remember that. Make sure that you maintain the decorum of the discussions. Okay. Lateral flexion was not monitored for centralization and peripheralization. If anybody shows that proof, I'll give you a free lifetime AOMPT membership. Okay. I'll be very happy to have members like that who can teach me. Okay. So coming back to the point, remember, their primary focus was flexion extension, and they were trying to correct the lateral flexion by keeping the hand. Okay, when the patient is doing the extension, you might give a lateral flexion force, but you are not evaluating the centralization and peripheralization for the lateral flexion and rotations. Even if you feel that it is there for lateral flexion and rotations, they have not evaluated the centralization and peripheralization for combined three-dimensional positions. So that means extension with the lateral flexion with rotations, okay, and flexion with the lateral flexion with rotations. Nowhere mentioned three-dimensional. Why three-dimensional is needed? Because all our functional activities are three-dimensional. So we need to think in a triplanar perspective. Okay. Remember, if you are concentrating on the patient, you think that if I am a patient, will I have low back pain only with flexion? No. I might have flexion with lateral flexion. Okay. I might have flexion with rotation, okay, as a problem. So we have to address that three-dimensional plane. Okay. So this is again another extension from the MDT to the MFDT. Utilization of frontal plane force is only giving the force. Okay, we are not assessing the movements. Okay, so again I repeat, be very clear with your foundation knowledge, and then I will give you an open forum now itself to discuss directly. Okay, don't confuse others. Okay, it is not a good thing when you are actually talking about knowledge. Okay, my intention today is not actually what is called as tell the drawbacks of the McKinsey concept. No, my intention today is to make the patients better. Okay, don't stick with this technique-based approach where you are screening the patient, selecting the patient for the technique. Patient not suitable, don't use. Okay, as per the description of the concept, if the patient is not fitting, don't use. I don't want that method. I want a method where clinically we are treating a patient where however the patient is, not only this, the motor control, neural mobilization, okay, and then try to give a best management for the patient. That's what my, so that's the reason why I have extended this approach. And remember, this extension of the approach is done anecdotally. It is based upon my pathophysiology, pathomechanical understanding. As I was telling in the point 3 of the webinar, okay, the webinar flyer, point 3, I have mentioned that it's my personal experience. It's level 5 evidence. Okay. So don't think about anything in terms of much higher. Don't complicate life. Okay. Use your knowledge and wisdom and see whether it fits into the picture. Okay. Whether did they talk about three-dimensional? All participants. McKinsey concept, original mechanical diagnosis and therapy, did they concentrate on three-dimensional? Yes or no? Three-dimensional means flexion extension, lateral flexions, rotations. All of them have been assessed for centralization and peripheralization, or combined positions, that is extension, lateral flexion, and rotations. Whether in that combined position, whether there is a peripheralization or centralization. Was it assessed in the MDT, mechanical diagnosis therapy? Yes or no? Over to the chat. Waiting for your responses from the chat. So McKinsey utilizes three-dimensional forces. McKinsey assesses centralization and peripheralization in lateral flexional rotations. Then you say yes. McKinsey assesses in extension, lateral flexion, rotation, combined position, centralization, peripheralization. Then you say yes. If you feel it is no, it is no. It is there mentioned only flexion extension. Assessment is there lateral flexions. Assessment is there rotations, but it is not giving the same emphasis as flexion extension. Okay, that's what I try to mean. Okay, get my wording right. Okay, the focus that is given on sagittal plane movements, the treatments which were divided into flexion regime or extension regime. Okay, that much extent it is not given to the lateral flexion or the rotations. That is the frontal or the transverse planes, and then the next one is the combined ones. Okay, although combined one is Edwards concept, but still, whenever we are talking about directional preference, we are talking about what is called as centralization, peripheralization. We are monitoring that. What is called as red light, amber light, green light. Red light is peripheralization with worsening of symptoms. Amber light is in between. Green light, centralization with reduction of symptoms. Okay, that is green light, traffic signal concept of McKinsey. Red light, I repeat, peripheralization with worsening of symptoms. Okay, so that means that direction you should not go, but you can do the opposite. Okay, green light is centralization with reduction of symptoms. So you are happy that you got the right direction. Okay, so that is green light. Amber is you have a peripheralization, but the symptom is reduced. Intensity is reduced. Distribution is more, but the intensity is less. You're confused. That is amber light. And the next one, centralization is there. Symptom is only felt in the neck, not in the hand. But symptom is intensity is more. You're happy that it is centralized, but the intensity is more. Again, you are confused. That is amber light. The amber light situation is very, very difficult to handle in the original concept. Whereas in MFDT, we are going to have why there is increase in symptom with the centralization. Because it is not just the movements, the kinematics, there are some kind of kinetics, okay, which can be the muscle imbalances. Remember, myofascial dysfunctions have been discussed only in terms of tightness in the original mechanical diagnosis therapy, where a tight muscle can restrict the opposite direction movements in a dysfunction syndrome. But here, muscle spasm can exist. Okay. You have a radiculopathy, disc bulge, you can have a spasm. Did the original mechanical diagnosis therapy mention anything about muscle spasm? Yes or no? Did the original McKinsey concept explain about myofascial adhesions? Okay. Myofascial release was there before McKinsey concept itself. Okay. So whether they have used or not used. Okay. And then next one, did the original concept address motor control, activation of the muscles, core, or any kind of those days which were isometric exercises was there. Okay, we didn't know that we are activating the deep cervical flexors. We are activating all the muscles. Okay, isometric neck exercises. Okay, people used to recover. We still know that for cervical spondylosis, you give isometric neck exercises, they get better. But without our knowledge, we were giving strengthening to the or endurance training to the deep cervical short flexors, the stabilizers. So yes, all participants, they agree. Okay, there are some people who do not agree because if there's a traffic jam in their mind. Okay, so if you have parked the car, okay, you are the cause for the traffic jam. Okay, if you are moving, if you are progressive, okay, you are trying to learn, you are integrate other concepts, that means you are going to go in a smooth flow of improving your knowledge. The moment you think that the existing knowledge is the best, that is when traffic jam starts developing. Okay, so always remember this message. So coming to the next aspect, so we are going to include the myofascial dysfunctions. Okay, how we can actually integrate with the McKenzie. Even muscle also, if there is spasm, can you say it's a derangement syndrome? Because there is an injury, that's why there is spasm. Okay, it's protecting for an injury. Okay, so remember, those who want clear explanations on MFDT, join the package course. It's as simple as that. Okay, with all my smile, I'm happy to invite you to join the package course, Mechano functional diagnosis. Okay, so remember, what is the existing gap? How we can make it better for the patient? That's the focus of this interactive webinar. Okay, it is not like one-way teaching where I am providing some kind of spoon feeding materials, or I give some course materials and then you keep depending on other ones. Okay, so always remember, what is the purpose? Clinical. Okay, how we are going to actually address. Okay, so we see that some participants are really getting restless. I don't know why. Okay, so we can make them happy. Okay, okay, so that we maintain the learning environment, positive learning environment, which is very important. We are not here to attack each other. We are not here to criticize each other. We are here to work with each other. We are here to learn from each other so that we can make a better patient care. Okay. So always, it's important now to realize the fact that, okay, there are some improvisations needed. I have told the aspects of improvisation, how well we can improvise together. Okay, I was talking about muscle spasm being a derangement syndrome. How many of you think muscle spasm can be a derangement syndrome? Yes or no? On chat. Muscle injury also, muscle tear. Will it be a derangement syndrome? Can it be? Next question I will put, whether the original McKenzie concept focused on myofascial injuries. Okay, so now the question is whether muscle spasm can be derangement syndrome, whether muscle tightness can be a dysfunction syndrome, whether what is called as muscle weakness, okay, the lengthening of the muscle. Okay, we think that when we are in an abnormal posture, what happens to these muscles? Okay, they get lengthened. Once they get lengthened beyond a particular length, okay, they go for the creep and micro trauma, okay, which stimulate the free nerve endings, creating the pain. Okay, and I correct the posture, resting length comes back, okay, and the subject feels less pain. Okay, so that means a lengthening of the muscle. Remember, kinetic control. There is an approach in UK, kinetic control international. They provide courses on what is called as uncontrolled lengthening of the muscle. Okay, I am sitting in this posture. It does not mean that the joint is getting compressed. Okay, disc is getting compressed. First, I should realize that muscles are lengthening, because when I do this, It's the eccentric contraction of the muscles. Okay, so the muscles are loaded first. However, after some time, the muscles give way, and then ligaments are loaded. Okay, so first is muscles are loaded, next is the ligaments are loaded, next is the joints are loaded. Okay, you can't think every problem is an articular. Okay, you have to think in terms of beyond that into myofascial, which is a lengthening, the what is called as the uncontrolled lengthening, okay, of the muscles. Okay, every muscle, every segment, the hypothesis behind the kinetic control is every musculoskeletal problem starts with the motor control issue, and that motor control issue begins with lengthening of a particular muscle. Okay, so if you are doing an excessive internal rotation, external rotators are getting lengthening. Okay, so that is the primary first focus. So that lengthened muscle you identify, and then you activate them, and then improve their eccentric control. The subject becomes symptom free. Okay, so here we are. That lengthening, uncontrolled lengthening of the muscle segment, can it be considered as postural syndrome? Can the tightness or the adhesions, okay, adhesion means the fascia sticking to the muscle, okay, tightness means the muscle length itself, origin to insertion, it is reduced. Okay, in this scenario, the tightness or adhesion, can you consider as dysfunction syndrome? And the injury and spasm, okay, muscles being very sensitive, it can happen in central mechanism also, okay? But peripherally when you talk, can you say it is a derangement syndrome? Okay, so all the three, I wish to see how the participants feel, yes or no. Okay, I was explaining for the nerves in terms of nerve tightness, okay, or nerve lengthening, or can be postural. Entrapment neuropathies can be dysfunction syndrome, and nerve injuries, okay, can be the derangement syndrome with the referred or the radicular pain. Remember, even in radicular pain, only a compression can cause radicular pain. So that is a dysfunction syndrome. Only a nerve root being tight or nerve root being in traction, okay, pulled always because of a droopy shoulder, okay, that also can cause radicular pain. Okay, that is postural syndrome. Whereas if there is the nucleus pulposus gets chemically irritating the nerve root and producing the shooting symptoms, then you think about derangement syndrome. Okay, so always you are coming to a picture now. Okay, same way muscles also. I am asking you now to put in the chat to tell yes or no whether it is possible that muscle spasm, muscle injury can be a derangement syndrome. Muscle tightness and adhesions, can it be the dysfunction syndrome? And whether muscle lengthening, okay, lengthening, uncontrolled motion, the first initial part, what was proposed by Kinetic Control International, can that be the beginning, what is called as the postural syndrome for the muscle? Okay, due appreciation to the opinions what we received from the participants. Yes, of course, you know, we have yes from the participants. Okay, okay, the next question is, does McKenzie concept, the original description, mechanical diagnosis and therapy, describe about myofascial dysfunctions and classifying them into postural dysfunction derangement? Okay, yes or no? Does it concentrate only on the articular aspect? Then you put that it is no. Okay, myofascial dysfunctions never has been discussed in the McKenzie concept. Original one, tell that no. Okay, so that's where we have. So that means all the dysfunctions, whether it is neural, whether it is myofascial, whether it is articular, also hypermobility, also we should be able to treat. Okay, that is when we are going to get the picture of functional. And remember, in AOMPT, prior to the functional one is a complicated, I can say complicated in one way because we integrate articular, myofascial and neural into a single technique called as AMNMT. Okay, arthro, myo, neuro, manual therapy, AMNMT. It's a registered approach of the AOMPT. So this approach has McKinsey. Okay. During the approach, when I was taking practical demonstration, 20 days I took the practical demonstration package. Many of the members have attended. They saw that in between I was using McKinsey. Same way, here McKinsey, when it comes to MFDT also, before functional, we have a multi-structural treatment, which is AMNMT. Okay. So MFDT in the later steps has AMNMT, and then comes to functional transitions. Okay. So that's where I'm giving an overall summary about this mechano-functional diagnosis and therapy. I have already mentioned, okay, my intention originally was to teach the mechanical diagnosis and therapy, because before we go to MFDT, it is best that you know MDT. Okay. But because we got objection from the McKinsey Institute International, okay, I can only give my opinion on the mechanical diagnosis and therapy. I cannot teach the mechanical diagnosis and therapy. Okay. Only the McKinsey Institute International instructors can teach. Okay. So they have that copyright of the terminology also. You cannot use McKinsey concept. You cannot use the photo of McKinsey. Okay. You cannot, what is called as mechanical diagnosis and therapy, you cannot use that word together. You can use only mechanical, only diagnosis, only therapy, no problem. But mechanical diagnosis and therapy, you cannot use. Okay. So these are all international copyrights. And as a editorial board member for 26 journals, and also peer reviewer for more than 50 journals, okay, I have to respect the copyrights, okay, international. I cannot violate. So what I did, I changed the terminology in consultation with our global experts of AOMPT, and then made better that don't teach the MDT, okay, improvise the MDT and see the loopholes in MDT, and then make it clinical patient-centered, that is MFDT, okay. So remember, for participants, many of you might have been thinking that we wanted to do McKinsey concept. Why are we listening about something else? Don't think like that. McKinsey created the concept with an open mind to help the patient. Okay. Stick with the original thought of Robin McKenzie. Don't listen to his students. Okay. Because students are commercializing the concept. Okay. With due respect to the organization, remember, although they are maintaining the quality of instructions, I don't think the certified instructors are doing justice. Okay. Or even narrowing a technique into what is called as certified practitioner, utilize the evaluation form. That evaluation form only you will use for all the patients. How it is possible? Okay. Is the form validated? Okay. Is it multidimensional? Is it what is called as biopsychosocial? Okay. Then how it can withstand the time? Okay. So over the period of time, MDT has become only a commercially distributed concept, not a clinically viable and feasible method. Clinically, sometimes it's too simple for people to think that flexion regime, extension regime, okay, give some of these exercises. See which one the patient is getting better, give that exercises. Okay. Cannot be like this. Okay. Even the self-management strategy, what originally prescribed also, patients have to do lifelong. They should keep the lumbar roll. They should keep an erect posture. They should take activity breaks. Keep doing the extension. Okay. If the symptom is more, they should do prone lying. They should again maintain the extension. If it is stenosis, there was a question. Remember that in stenosis, don't go by the condition, go by centralization and peripheralization. If flexion is centralizing, you can give the flexion exercises in stenosis. Even spondylolisthesis, extension will peripheralize. So you have to assess the flexion. If it centralizes, you can give the flexion regime. That's what is the original MDT. In MFDT, I would say spondylolisthesis involve stabilization training because the disorder of instability. Okay. Stenosis, I would say check whether the stenosis is from the disc or from the facet joint. Facet joint means extension is harmful. Disc means flexion is harmful. Stenosis, whether it is the central stenosis which will be influenced with the flexion, increasing the canal, extension, reducing the canal. Okay, flexion, increasing the canal. Okay, that is the central stenosis. But if it is foraminal stenosis, then the extension will reduce, flexion will increase the canal. Same way, same side lateral flexion will reduce the canal. Okay, opposite side lateral flexion will open the canal. Okay, and then rotations, same side is reducing or opposite side is reducing, depends upon the coupled motion. Coupled motion is the spontaneous rotations described as part of muscle energy techniques, not by McKinsey. Okay, so we need to integrate everywhere, wherever we can put that picture, so that we can fit the puzzle properly and then make sure that the patient wins. Okay, that's where we are going to get a picture of Mechano functional diagnosis and therapy. So I take this opportunity to open the session now for the questions which are specifically directly there. Okay, you can just put the question. If your question is sensible, I will unmute you. You can directly speak on the screen. Okay, so that we can open the sessions. Others who are having some other commitments, please feel free to get on with your work. For all the registered participants, I'll be sending this video link. Okay, so you can watch this video of this webinar session so that you get more highlights, more inputs, more refreshing, reviewing, gathering the information, you can integrate. Because sometimes you might find that I'm telling too much of information in a very short period of time. Remember, I wish to do justice with knowledge, not with time. Okay, it's like 1 hour, this much only. No, knowledge is this much, I have to give it. Okay, so that's why AOMPT is rated 5 out of 5 stars by nearly 6,000 followers on Facebook. Okay, more than any manual therapy academy in the world, whole world. Okay, AOMPT is the only academy which is rated 5 out of 5 stars. Why? Knowledge. Okay, learning. So with that message, I wish all the participants the best of luck to get more and more insights into improving your intellect towards a better patient care. Okay, those who wish to register for the package, please contact me directly on the WhatsApp. I am posting on the WhatsApp group. You have my WhatsApp number. Okay, unless you do some mischief and then I blocked you on WhatsApp. Okay, otherwise everyone can contact me. Okay, so remember that in what kind of mischief, this kind of non-professional attitude, sometimes we tend to bark, shout, and then we keep moving. We don't bother about what is happening. The purpose of this is a discussion to bring about the betterment of knowledge. Some people feel that what they know only is knowledge. Okay? That's why everybody is not the best. Okay? Even if they become best, anyone can become best. Everybody is not great. What is great? You make everyone the best. Those are the people who are the greats. Best people will come, they will go. But the great people will live even after their death. Okay. So I wish all of you the best of luck to become great physical therapists who can make fellow colleagues, subordinates, students, and patients better and create a better world. On the eve of the Festival of Lights for India, wish you all a happy and a very, very prosperous Diwali, to make sure that the light of knowledge glows from your within, okay, reflects in your vision and creates the change through your performance. Okay, I open the session for the questions, so put it on chat so that I can unmute you on the screen in the video itself. Everyone, towards the closing of this session, so wish all of you the best of luck and a great Mechano functional diagnosis and therapy. Signing off. See you all. Bye-bye.